emphasis either, but you need to do that in order to choose either English or French. So again, my name is Penny Stewart, and I'd like to start our meeting today with a reflection. Although we're all meeting virtually, all of us carry out our intellectual work on specific Indigenous, First Nations, and Métis territory. Some of these territories are governed by treaties, but some are still unceded. I would ask all of us here today to reflect on the conditions under which we occupy these lands today and moving forward. Today I'm speaking from Toronto, where the signed treaty is referred to as the Toronto Purchase, and it applies to all the land east of Brown's Line, for those of you who know it, to Woodbine and north to Newmarket. Want to acknowledge this land as the traditional territory of the Wendat, Anishinaabe, Haudenosaunee, Métis, and Mississauga of the Credit peoples. On behalf of the Harry Crowe Foundation, I am really pleased to introduce this year's recipient of the Foundation's annual Olivieri Lectureship in Medical Ethics. Before I actually introduce our speaker, however, I want to give you just a brief description of the lectureship. The lectureship was established in 2013 by the family of Dr. Fernando Anthony, known as Red, Olivieri, in honor of his memory and his lifelong commitment to the defense of integrity in medical science. It is, as many of us know, a distinguished family. As many of you here will know, Dr. Olivieri's daughter, Nancy, has had a long association with the CAUT and is herself a very formidable champion of research integrity in medical research. But to return to Dr. Olivieri Sr., he was the only son and the youngest child of Italian immigrants who I believe arrived in Hamilton in the very early years of the 20th century. He had 3 older sisters, so a favored child. He graduated in medicine in 1948, and his career was distinguished by his passion for justice and his fight against undeserved privilege and hierarchy. Throughout his 47 years as a pediatrician, he was uncompromising in his devotion and care for his young patients. And a small anecdote, but Nancy Olivieri tells about the day in the 1960s when, after hospital rounds, she and her father were driving home. Her father pointed to a set of stoplights and commented that integrity is stopping at the red lights when no one is looking. By the time he retired in 1968, Dr. Olivieri had become very concerned about the threat to his patients arising from the commercialization of medical care, an issue as we all know here, over the years has become increasingly troublesome. So in that spirit, and in the spirit of Dr. Olivieri, it gives me a great pleasure today to introduce Dr. Maxwell Smith, our speaker for today. Dr. Smith is a bioethicist, an assistant professor in the Faculty of Health Sciences and the Rotman Institute of Philosophy at Western University. Trained in philosophy, bioethics, and public health, Dr. Smith's research is in the area of public health ethics, with a focus on the ethics of preparing for and responding to infectious diseases, as well as the ethical requirements of health equity and social justice in public health policy, practice, and research, making him one of the very few people, I think, that was well prepared for the pandemic. During the COVID-19 pandemic, Dr. Smith co-chaired Ontario's COVID-19 bioethics table and served on Ontario's COVID-19 vaccine distribution task force. He also served with the Public Health Agency of Canada Public Health Ethics Consultative Group, the World Health Organization Ethics in COVID-19 Working Group, and the World Health Organization Accelerator Ethics and Governance Working Group. Professor Smith is a prolific and wide-ranging researcher on the national and international arena. Since 2020, at least by my count, he has been the lead author or co-author of some 20 articles addressing ethical aspects of key COVID issues, including such issues as the fair allocation of scarce medical resources, publication ethics during public health emergencies such as COVID, balancing speed and equity in the rollout of vaccines. During the same period, he was actively involved in more than a dozen further policy briefs or reports. Today, Dr. Smith will address the topic, navigating the pandemic's most difficult decisions. And I'll turn it over to you, Dr. Smith, and welcome.
Thanks very much for that wonderful introduction, Penny. And thank you to the Harry Crowe Foundation and to CAUT for the wonderful honor of giving the Olivieri lectureship this year. And thanks to everyone for taking time out of your day to join for this discussion, wherever you might be in Canada. I'm joining you from London, Ontario, and the traditional lands of the Anishinaabe, Haudenosaunee, Lenape, and Chinantan nations. So I was asked to focus my talk on ethical issues in the pandemic. And this, of course, is not a very small task. There have been, of course, many, many different issues that we've experienced over the course of the past 20 months that, of course, have been very, very controversial and have raised a host of different ethical issues. So each of the issues you see on the screen here really involve fundamental ethical tensions, and they're issues that we've had to grapple with and come to some decisions about over the past 20 months. And we really need evidence and science to inform how we make decisions about these issues, but science can't tell us what the right thing to do when it comes to, for instance, triaging critical care or prioritizing vaccination or even mandating vaccination. So I'll invite you to think back over the course of the past 20 months and think about the times you may have remarked about whether the government or even the world has done something that you have felt is wrong, unfair, or inequitable. And I think this, I think a lot of us will think of a lot of instances where we've thought that over the past 20 months. And I think this suggests that some of the main deficits in how we've responded to the pandemic haven't necessarily been due to a lack of science, a lack of evidence, or a lack of public health measures that could be used to curb the spread of this pandemic, but rather they really reflect failures of navigating what the right thing to do is in response to this pandemic. And so for this lecture, instead of focusing on any one of these issues, which we could certainly do and take up all of the time to do so, I thought what might be of greater value is attempt to distill some key insights about how ethics has been navigated in relation to the pandemic's most difficult decisions, in particular by identifying key deficits in how ethics has been navigated with the aim of clarifying and refining the role of ethics and ethical analysis and the role it ought to play in pandemic response. So I'll disclose that I've served in a number of roles that Penny mentioned over the past 20 months, where I've provided ethics advice to governments or organizations on the ethics of pandemic response. And I do that to note that the views I present in this presentation are my own and not the views of those organizations or governments. But I also wanted to disclose this in order to really contextualize my remarks, that the ethical considerations and insights that I hope to distill are really a reflection of my experiences navigating these thorny issues in practice. And so in order to not be entirely boring, what I hoped to do was not only to articulate different ethical insights about how we might think about ethics in pandemics, but ground those issues within actual examples of some of the most controversial and difficult pandemic decisions that we've had to make. So the first issue that I want to focus on is a deficit of ethics as merely problematizing issues. And I'll speak to the example of critical care triage to illustrate that point. The second thing I want to do is to discuss the failure to appreciate population level ethics. And for that, I'll illustrate that point by looking at the issue of extending the vaccine dose intervals, which I'm sure everyone will be familiar with. Third, I want to look at the failure to really appreciate trade-offs during this pandemic, and in particular, look at the issue of lockdowns to illustrate that point. Second last, I want to focus on the failure to understand and transparently communicate ethical commitments that we have, and I'll reflect on some of my experiences with Ontario's Vaccine Distribution Task Force to illustrate that point. And then finally, I want to say something about our tendency to disregard the practical challenges that actually face decision makers when we're thinking through the ethics of some of the gnarly issues that we faced. And for that, I'll explore the issue of mandatory vaccination. And because I want to have as robust a conversation as possible, I want to leave significant time at the end for questions and discussion where you can ask me about any of my role or my experience with any of these different issues. Okay, so the first that I want to focus on is this deficit, as I see, being ethics as merely problematizing issues. So in my experience, ethics often focuses on external critique, problematizing, and identifying ethical issues and concerns. This is really the bread and butter of what I do in academia. I identify issues, I write about them, I publish those issues, and I hope that we can all contribute to these conversations, that over time, we can iteratively try to address those issues. And I want to argue that this has been a problem in this pandemic, and it hasn't been sufficient to address some of the issues that we've needed to address. And as I mentioned, I want to explore the issue of triaging critical care as why this has been particularly problematic, or why we might consider it to be a deficit. So in March of 2020, really early on in the pandemic, we were thinking that we might be facing a prospect of having to triage critical care in early April, given the increasing demand for critical care resources and our otherwise limited or scarce supply of critical care resources like ventilators and ICU beds. And so Ontario's bioethics table generated a draft of how we ought to triage critical care if we were to face that particular scenario. And central to setting priorities and thinking through this, we have to think, on the one hand, these are very scarce resources, so how do we use them efficiently and effectively? And on the other hand, how do we make sure that we use them fairly, that people have fair opportunities to benefit from these scarce resources? And really, there's four main ways that we thought about that we might allocate critical care resources in the pandemic if we were to get to that particular state of affairs. The first is to do nothing, right? So we could just proceed based on the status quo, which is effectively a first come, first serve sort of approach, where whoever gets sick and presents for critical care, they would get a bed. And as soon as we run out of beds, that would be it. And as soon as a bed opens up, it would really be first come, first served again. And we felt that this was problematic for a number of reasons. First, it's not a very efficient use of resources, because you might use resources for patients that might actually confer much benefit from those resources where others might. And it's not particularly fair either, because we know that the healthcare system is replete with biases and with structural issues of discrimination. And we'd want to make sure that the process by which we make these really tough decisions is systematic and addresses and tries to mitigate some of those biases. We also know that a first come, first serve approach would tend to disadvantage those that get sicker earlier in the pandemic and disadvantage those later in the pandemic. So we felt that that wasn't necessarily appropriate. A second approach would be to randomly allocate the resources. That seems very equal, giving everyone equal chances. But again, we felt that that was problematic because it wouldn't be using the resources as efficiently as possible. A third approach, given our concern with fairness, would be to look and try to prioritize populations who experience disadvantage or marginalization and give extra priority to those groups. And yet, we found that that was really difficult to operationalize, because there's really no accepted way to reliably identify and adjudicate between competing and intersecting forms of disadvantage, whether it's racism or sexism or colonialism or socioeconomic status. And so while that seemed good in theory, it really wasn't something that we could operationalize. And so finally, we thought, the use of strictly clinical factors would be perhaps the best bet. And this would be looking at individuals' probability of surviving their acute illness in critical care. And we would do whatever we could to make sure that other sorts of issues were not part of the calculus. And so those with very low probability of surviving based on clinical factors alone would be given lower priority for critical care. However, when we engaged many stakeholders on this issue, we knew that, and we heard that clinical factors and tools themselves can perpetuate disadvantage and inequity. And so often there was an interest in not using that approach. And so we were left in this position of potentially facing the need to triage critical care very soon, and we didn't have a consensus about how to proceed. And we heard much criticism about the approach that we were selecting using just clinical factors to determine who ought to be prioritized. But when asked what the better alternative is, we often heard, I don't know, but not that. And that puts you in a very difficult position when you are imminently facing potentially the need to implement such a protocol. And so that leads to my conclusion that the problematizing function of ethics remains critical. We need to problematize the different approaches we come up with, but unless we seek to be irrelevant in ethics, we must aim to provide practical guidance to decision makers about how to proceed, even when the most ethically justifiable path forward is not ideal. So it's not enough to say that there's problems with a particular approach. We need to think about and propose alternatives. We can't simply leave it at the problem. Okay, second, I think that there was a failure to appreciate population level ethics as opposed to or distinct from medical ethics or bioethics over the course of this pandemic. Standards or norms or analyses that commonly guide action in everyday medical ethics or bioethics arguably may be inadequate in a public health emergency. Public health emergencies like pandemics raise questions about the types of individual sacrifices that can justifiably be made in order to protect and promote the population's health. And I think a great example of this is the recommendation by the National Advisory Committee on Immunization, which ended up being adopted across the country, to increase the interval between your first vaccine dose and your second vaccine dose from the 3 or 4 weeks studied during the clinical trials to the up to 16 weeks or 4 months that was being recommended by NACI. And here there was a lot of frustration and concern that extending that dose might have particularly deleterious effects for an individual who might have to wait a little bit longer for their second dose. But the argument and the rationale for extending that dose was really to ensure that first doses could go into more arms and give some protection at least to a greater majority of the population. So sometimes you heard healthcare workers who now needed to extend their dose, being concerned that they didn't have the protection that they otherwise could have from 2 doses. And yet, on the other hand, some of their patients could actually get a first dose to make sure that they were receiving some degree of protection. And I think the debate there really didn't focus on the population level benefits and articulate what those were as effectively as they could have done. And a lot of the pushback to that particular decision was from a place of thinking about what is owed to the individual at the sort of precluding thinking about what we might owe to populations. The third issue or insight about the past 20 months has really been that ethics and policymakers in general have failed to meaningfully navigate trade-offs. We're in a pandemic, and we can point to some countries that have done quite well in its response, but I think we can agree that some degree of harm will be unavoidable. This is a public health emergency of international concern. And so it's insufficient to point to the harm that may arise with one policy option as a justification for avoiding it and adopting a different policy option. The mere presence of harm isn't sufficient warrant to render that policy option unjustified. And yet I think this is what we've heard most in social media or media more generally, just pointing to the harm of one policy option as a justification for not pursuing it. And so, we've seen all sorts of funny memes about this being circulated that, there's this trade-off between public health on the one hand and the economy. And there's really been people pointing to the harms that may accrue in the economy or socioeconomic sort of status. And that is sufficient to say we ought not to implement measures that could protect the public health. That's not necessarily wrong, but I think that we need to think about the benefits and risks on both sides equally when we do these analyses. And I think this was very evident in discussions and analyses about school closures. I've been at many tables where people would point to the particularly mental health harms that children would experience from the result of school closures. And this is no doubt true, but often that's where the conversation stopped, that the mere threat of mental health harms was sufficient to argue that school closures would not be ethically justified. And of course, they may be ethically justified, and perhaps those harms are necessary in order to prevent further harms and harms to others, and perhaps even harms to the mental health of children as well. So I think we're fairly unsophisticated in thinking through the trade-offs that exist in a decision like that. Similarly, with conversations around vaccination passports and vaccination mandates, there's many who will argue that these in some way infringe upon freedom, freedoms of movement, other sort of liberties, and that's sufficient to suggest that we ought not to pursue passports or mandates. I think it's very well true that mandates and passports can infringe upon people's freedoms, but again, that we experience some harms or risks associated with these policies isn't necessarily sufficient justification to say we ought not to pursue them. We need a broader analysis of the benefits and harms on both sides of the debate. I really like this quote by Winston Churchill, where he said in 1938 that we seem to be very near the bleak choice between war and shame. My feeling is that we shall choose shame and then have war thrown in a little bit later on even more adverse terms than at present. I think the decisions that governments have had to make have often been characterized as this bleak choice between greater numbers of illness and deaths, which would be expected if we just keep businesses and schools open, and economic deprivation on the other hand, which would be expected if businesses and schools are closed. Yet much like as Churchill warned in this quote, I believe, if we choose to keep businesses and schools open despite increases in illness and deaths that might be likely to occur, it's possible we'll have economic deprivation thrown in a little later and perhaps on even more adverse terms than at present. And I think we can look to the example of Austria at the moment where we make certain decisions to avert harms. They removed in many instances mask mandates and open up their economy, only to have to implement even more aggressive measures, full country lockdown and a mandate that would apply to every citizen. And so I think this quote nicely illustrates that we need to think about how these things interact rather than just pointing to the harms on one side. We can point to a lot of different examples where this exists. Being on the vaccine task force in Ontario, I was acutely aware of all of the calls for different population groups to be vaccinated, and all of them are legitimate because everyone is susceptible to illness here, and there are many good moral claims to be prioritized. So we heard about teachers and education workers needing to be prioritized, persons with developmental disabilities, those that work in correctional facilities, those who are homeless, shelter staff, and those working with such populations, RCMP and other police and emergency medical response workers, and even theater actors. Like, I don't know why NHL hockey players are theater actors, but calls for all sorts of different groups to be prioritized. And again, I think there are good reasons to prioritize each of these groups or give some priority to each of these groups. But what's often missing is who you would be deprioritizing as a result. So when I received emails indicating that teachers ought to be prioritized, they would present very good reasons why that ought to be the case, but wouldn't necessarily articulate why they ought to receive greater priority than an 80-year-old or someone who might be working in the homeless system shelter. And good ethics requires that we navigate how these trade-offs occur and how they might be justified. Of course, this is also playing out at the moment when it comes to the debate around providing third doses or boosters in high-income countries like Canada, and also the need for better and greater global vaccine equity. And so you often hear the same people providing the same arguments that we need to address global vaccine inequity now, and also arguing we need to provide boosters now. And this, in many instances, is a reflection of the inability to really think about the trade-offs that exist when we make these claims. So the conclusion there is that ethics should seek to prevent and mitigate harms wherever it can, of course, but where harms are unavoidable, a key ethical responsibility exists to explicitly reason about which harms are most ethically objectionable. So is it mental health harms for this group? Is it economic harms over here? And where harms would be best located or distributed. It's not enough to simply point to the fact that a harm might exist to suggest that we ought not to pursue that particular policy. Okay, fourth, second last. There has been a failure, I think, to understand and transparently communicate ethical commitments. I think, across the board, we hear about commitments to equity and fairness and these sorts of things. I think we can all agree that these are important commitments to have, but then we can, of course, disagree bitterly about what that actually means in practice. And so we really need to do better to articulate and interrogate what those ideas require for policy and practice, and then transparently communicate how that relates to policy and practice to the public. So this is the ethical framework for COVID-19 vaccine distribution that I helped to lead for the province of Ontario. I put this up just to indicate that equity was a particularly important value that was meant to guide all of our work in setting priorities and distributing vaccines. And this led to the identification of different priority groups on January 13th, very soon or early in the rollout. The province released its strategy. And it said that we would support other populations and communities, in addition to, say, healthcare workers and those over the age of 80, who may be facing barriers related to the determinants of health across Ontario, who are at greater risk of COVID and severe outcomes from COVID. And this included Black and other racialized populations. So this really reflected the fact that some populations, due to the social determinants of health, are at greater risk of experiencing severe outcomes from COVID-19. And we wanted to make sure that we provided some priority to those groups in the rollout. And so very helpfully, Ontario's Science Table developed a strategy for distributing vaccines in Ontario, where they argued that we shouldn't just focus on age, which is a very good proxy for severe outcomes from COVID, but also neighborhood, which would capture community-based risks and the social determinants of health. And in their policy brief, they developed a really nice evidence-based matrix that broke down the different communities in Ontario into deciles and showed that, look, if you are 80 years old in one community, you might be at greater risk than an 80-year-old in another community. But more critically, if you look on the left side of this graph, you can see that a 50 to 54-year-old is at a particularly high risk of, in this case, death or hospitalization that's comparable in some instances to a 70-year-old who's living in another community. So if we just went by age alone in the rollout of vaccines, we would miss the fact that some younger people are at the same risk as older adults just because of the community they live in and the social determinants of health that affect them. And so what we did in Ontario was said, when we are rolling out vaccines to everyone over the age of 70, we would at the same time focus on younger age populations, those 50 and above, in key communities. And these are understood in terms of your postal code, which map on really well to material deprivation and what a metric called ethnic concentration, to make sure we're getting at those populations that are disproportionately affected by the determinants of health. And again, just to be very clear, the Science Table's guidance was based on the incidence of deaths and hospitalizations in those communities. It wasn't about the number of cases of COVID we were seeing or the case positivity rate in those communities. It was the burden of hospitalization and death, the most severe outcomes that we want to avoid. And this led to a fair amount of controversy and confusion. At the time, there was a lot of media attention at the hotspots, the so-called communities that were identified, who were getting that vaccine priority for younger ages, and they were identified as less hard hit by COVID in some instances. And this was really a failure to understand, and another way, a failure to transparently communicate that, in fact, those priority groups were being identified not because of the number of COVID cases that are experienced or the case positivity of COVID in those particular communities, but rather the burden of hospitalization and death that was experienced in those communities. And of course, if we look at equity, depending on either one of those metrics, you might actually look at different communities and prioritize different communities. And so it's very critical that we communicate very clearly about why equity requires that we focus on one metric over another metric. And that was a failure to transparently communicate that to the public, which led to this confusion. Interestingly, not long after, some sort of came alive to this issue and found that actually what is being done here is actually trying to address social inequity, something that many hadn't picked up on for the weeks that the strategy had been rolled out. And again, this speaks to the failure to transparently communicate the fact that we're trying to address social inequity here. We're trying to address those that might be disproportionately disadvantaged based on the social determinants of health, and perhaps by calling them hotspots, made it more difficult to understand that no, we're actually trying to focus on those who have poor socioeconomic status or Black and racialized populations who might be more disproportionately affected by COVID. Okay, and finally, I wanted to speak to a general issue that I found in ethics among ethicists and amongst policymakers who might opine in the media or elsewhere about how we might think about the ethics of different issues, and at the same time disregarding the practical challenges that are actually faced by decision makers. A lot of my colleagues, are doing really fantastic work in this area, but some of them are quick to go in the media or social media and opine about what is ethical or not ethical, while not really thinking through all of the really difficult practical challenges that decision makers are actually grappling with in trying to think through the policy response to those issues. And so just as one example, I thought I would discuss vaccine mandates in universities. So this is something that, of course, many universities across the country have been grappling with. I had the opportunity to speak with the president and provost of my university at the University of Western Ontario to think through the ethical dimensions of mandates. And there was a lot of criticism of how universities addressed this, at least initially and particularly in Ontario, because there was some delay, I suppose, in introducing policies for mandates. This was a particular article published in late July from the University of Western Ontario's Faculty Association, which was arguing that Western ought to implement a mandate, and it's been slow to address this particular issue that exists. What I found very interesting here is being sort of on the inside of a lot of these discussions is that decision makers often agree with the sentiment that is being raised or expressed in media or social media or otherwise. I happen to know that there was many decision makers who have been quite in favor of mandatory vaccination. They felt, yes, it can be ethically justified, can be legally justified, it can help to promote important public health goals, but that's different than trying to construct a policy that would actually implement a vaccine mandate in reality. And so decision makers like a university senior administration might agree that we should have mandatory vaccination, but would still need to grapple with the gnarly sort of practical issues that they will need to think about in such a policy, such as how vaccines that are administered in other countries but not approved by Health Canada might be accommodated. We have thousands and thousands of international students who might have received a Chinese or Russian vaccine, for instance. We need to think about, if we're going to have a mandate, is it going to apply to those students? We need to think very carefully about how a mandate will be enforced. It's one thing to say that you must be vaccinated. It's another thing to indicate how exactly we will enforce that and make sure that we're actually seeing the proof that people have been vaccinated. We need to think about the different penalties that might exist for, say, a tenured faculty member who says they're not going to align with the policy and get vaccinated, a staff member who won't get vaccinated, or a student that won't get vaccinated. What are we going to do with these different populations? We also need to think about whether the mandate should apply to those who will continue to work or study from home, who won't even be coming to campus. Should we have this extend to them on the off chance that they might need to come in for some reason? And how are we going to deal with things like religious or medical exemptions? What's the process going to be, and who's going to adjudicate the different requests for exemptions? I don't think any of these questions are insurmountable, and over the course of the months that followed in putting these policies in place, there were answers that were provided to them. And yet it takes a certain amount of time and engagement with communities, in particular, if we do this well, engaging with our faculty, staff, and student communities, to go from the conclusion that, yes, mandatory vaccination might be a good thing and can be supported, to having a policy that thinks through these various challenges that decision makers might face. And those that were calling on universities to come out in late July and indicate that if they support mandatory vaccination, then they ought to say so, I think failed to appreciate that they will immediately be hit by these questions and more. And if decision makers don't have answers to those questions, then they may threaten or lose the trust of their communities, who might think, well, you arrived at this decision, but you didn't think about all of the things that actually matter. Like, are we going to fire a tenured faculty member if they don't get vaccinated? This seems like something that must be thought about before we implement such a policy. And in fact, if we think that mandatory vaccination is in principle ethically justified, it could be that we don't have satisfactory ways to address all of these questions. I think we have been able to, but it could be the case that we don't have satisfactory ways to address these questions. And as a result, that might actually mean that it wouldn't be ethically justified to implement a mandate. So you can't necessarily indicate that there will be a policy that requires vaccination before addressing these questions, because addressing these questions is part and parcel of the moral calculus that is required to determine whether these ought to be ethically justified or not. And so I think this is something that we can apply to almost all of the issues in the pandemic, being at some of the tables where advice is being given to governments, that people are often very interested in seeing a particular outcome, but are uninterested in all of the different practical challenges that come along with it. And engaging with those practical challenges is critical, both to retain the trust of the public when you implement such policies, but also to arrive at a conclusion about whether they are ethical at all. So I'm going to conclude with just a few remarks, and then very happy to turn it over for questions and discussion. And again, it needn't be on the content that I've provided in this talk. If you have other general questions about the pandemic response and the role of ethics in that, I would be happy to answer them. So the first conclusion is that ethics must move beyond problematizing by providing practical guidance to decision makers, even where advice or solutions remain less than ideal. We do need to retain that problematizing function. We need to be critical, but we can't expect that just leaving it there will be satisfactory, because decision makers will be in a position in a public health emergency where decisions must be made, and they can't be left with, sort of in the lurch, not having a way forward that would be ethically justified despite the problems or flaws that solution might have. A reorientation toward population level ethics or public health ethics is required to adequately respond to issues that are unique to public health, or really just to health policy more general. If we try to apply the lens or frameworks of how we think about medical ethics or bioethics, the way in which we engage with patients and others in clinical settings, is going to be inadequate to think of population level issues. That doesn't mean that we should do away with them. There's still going to be critical ways to think about these issues, but they must be supplemented by the ways we think about issues that are unique to populations, that are unique to using the coercive power of governments to protect and promote health. Third, we need to do a better job of defending particular policy positions despite the harms that are likely to occur. We need to acknowledge that, yes, there's going to be harms if we lock down, there's going to be harms if we don't lock down. Simply pointing to the harms on either side isn't going to be sufficient to tell us what's right. We need to acknowledge that those harms will occur and ethically defend that this is where we think those harms would be best located or distributed given the state of affairs that we're faced with. Fourth, we must do better to explain and transparently communicate how ethical commitments like to equity or to solidarity actually translate into concrete policy and practices decisions. Sort of do the math, show us the homework of how you saying that we want to be equitable in the rollout of vaccines, for instance, actually translates to the prioritization of particular communities, and why that might be limited in some ways, that we can't think about every single individual and prioritize them in turn. It might be a blood instrument, but that is what's required, and that is the translation of that ethical commitment into policy and practice. And then finally, ethical positions on issues are of low value in my opinion, and might actually be harmful when they don't account for the practical, complex challenges faced by decision makers who are actually charged with addressing that issue via policy. It's very easy to opine on these issues and neglect the individual practical challenges that are actually faced in putting in these difficult policies that might apply to 15 million people or 36 million people. It is important to start perhaps with those ethical positions, but we need to navigate through those gnarly, practical, complex challenges that decision makers will actually be faced with if we want to come to an all things considered ethical conclusion about what we ought to do in respect to any pandemic issue. So I will shut up there. Thanks very much for your attention, and I would be happy to take any questions that you may have.
Well, thank you so much. That was a wonderful talk. So we can open it up. Let's use the raise hand function if we can. And let's open it up to questions. Do we have some questions to begin or comments? Let me ask you one. So I was thinking that there are so many parts of your talk that struck me as so interesting. Partly, I think, because many of the issues you raise is there is no public framework for talking about equity. Sorry, not equity, but ethics and ethical equity. So there are things that were presented throughout the pandemic as ideas, but rarely was there a discourse. At least I can't think of a public discourse that sort of named it as ethics. And so it's sort of a two-part thing. I think I was very struck by how you really hone in on how little discussion there has been on kind of ethical frameworks, even when the decisions are clearly about justice of some kind. And then I think the other part is, I wondered if you would have anything to say about, were governments ready to talk about ethics? I mean, there are all these tables that I think many of us didn't really know existed, but were states ready to do this? Is it commonplace for them? It wasn't reflected, at least in Ontario, in any kind of public statements, but just if you had a word to say about that.
Yeah, it's a fantastic question, Penny. You know, it's interesting because early on in the pandemic, and really to this day, in some instances, journalists will reach out to me and ask about, you know, the ethics of a particular issue because they might have seen a paper or press release released by my university about it. And the first question is, what does ethics have to do with any of this, right? And so it actually is this this jump that some people need to make to actually see these as overtly or explicitly ethical issues, despite the fact that everything that we're doing in this pandemic is flavored by ethical language. I often joke that even the arrows that are in grocery stores and pharmacies on the ground to tell you which way to go, people moralize that very significantly, right? That if you don't follow those arrows, you're absolutely wrong, and people get very frustrated by this. And on the flip side, people say, it's just arrows on the ground, settle down, it's not a big issue. So even trivial things like that are moralized. And yet we don't see these as overtly or explicitly ethical issues. And we need to do a better job if we're actually going to improve the failures that we've had in this pandemic. We're not going to get out of this if we don't really interrogate the ethical sort of nature or justification for these sorts of things. To your second question about whether this is reflected in government decision-making, or is this something that we engage with at these sorts of tables, it's kind of hit or miss, to be honest. You know, I've been in situations, including at the World Health Organization, where we talk about equity and the need to have a global distribution of vaccines that is equitable. And, you know, as ethicists, we say, well, we can wade into this discussion and give you lots to think about what would be equitable, because equity is an ethical value, right? It reflects philosophical thinking around justice. And yet we would get pushback from people saying, well, no, equity is a technical idea, right? It's not an ethical idea. And so there was some of that aversion to even putting it in those terms. The other force that pushed ethics perhaps out of the frame is this interest in being evidence-based or evidence-informed. And that's critical. We need to use the best available evidence to inform our decision-making. But sometimes people think that that means that values can't play a role, or that they don't play a role. And that's simply not the case. What ends up happening is we just end up sort of pushing those values down, and they more implicitly inform what we're doing rather than explicitly inform what we're doing. So I think we need to think about both evidence-informed and values-informed decision-making, make that explicit so that it's very clear how these different things interact to ultimately inform a decision that's made.
Thank you. Bill Bruno. You have to unmute yourself.
Oh, thank you. My question is essentially historical. There's been about 75 years of considerable success in persuading people, partly through education at the elementary and secondary school levels, and partly through public education to the whole community, for people of all ages, to accept that immunization against polio, smallpox, mumps, you name it, It's just part of the atmosphere. It's something we breathe from the beginning to the end of our lives and should be accepted almost passively. So something's gone wonky, something's gone wrong with the COVID business. What is it that's gone wrong? Why does the history not help us to find out how to make it right?
Yeah, fantastic question, Bill. Thanks for that. I think there's a number of things that have gone wrong, to be honest. One is the successes we've had in vaccination campaigns over the past 200 years have been a bit of our undoing, right? The fact that we've been so successful in mitigating and preventing these diseases, for a lot of the population, we don't understand the benefits of vaccination because it hasn't hit us like it has hit some generations. So that's part of the reason. A second reason is that, public health often operates very silently, right? It very significantly interferes with our lives, right? We're not allowed to pollute as much as we want. We can't market foods with whatever we want in them. There's so many things that we do in the name of public health that we're just simply unaware of. The pandemic has made it very clear the role of the state in interfering in our lives to protect our well-being. And that seems to many, I think, overbroad and overbearing on our liberties, even though these might be quite common things for the state to do. It's just been much more public. And then I think one of the biggest issues that, is something the World Health Organization identified before the pandemic as being one of the greatest global health challenges we're facing, is this issue around vaccine hesitancy fueled by misinformation. And the extent to which social media can perpetuate misinformation and false claims, and that can really sort of find roots in different communities, is a massive problem that perhaps, we've had to deal with misinformation and hesitancy since the beginning of vaccines, but I think it's becoming exacerbated given the role of social media. And so that's just perhaps one of the mechanisms that's making this even worse than it otherwise would be.
Thank you, Bill. Kevin.
Hi there. Thank you. Kevin McKay, a professor from Mohawk College. And thanks very much for your talk. I've been thinking about all of these things, as I'm sure most people have on the call for the past year and a half. I have two questions. So, and it's related to your experience as someone who's an academic working in the field, but who's also worked in the policy realm, sitting around those tables. One is, a lot of your presentation was about how ethical thinking or calculations are communicated to the public, right, and failings in that communication. And I'm wondering if you could comment a little bit. Question number one is the role that the perceived trustworthiness of legitimacy of the communicator factors into that. Because of course we had the horrible snafu right off the bat where, oh no, masks won't help. Oh no, wait, masks help, right? I mean, we had the continued open question of the origins of the virus and all that sort of stuff. So I just think there's been many times where, the official communicators have been compromised, let's say, in terms of their perceived authenticity or whatnot. The second question is, I'd love you to comment on the challenge where you can maybe come up with an ethical sort of matrix of different possibilities for a decision maker, right? But when you're trying to weigh cost and benefit, so for instance, when you talk about a lockdown, I mean, to me, a lot of what goes into weighing those costs and benefits is what degree of mitigation will there be of the harms involved in a lockdown. So case in point, I was someone who I think saw the public health utility of lockdowns, but was very frustrated at a perceived government mishandling of mitigating negative consequences to small businesses, the homelessness encampments, we're seeing that sort of stuff, right? So anyway, I know those are two big questions, but I'd love to get your thoughts on them.
Yeah, thanks, Kevin. Both really good questions. I think you've hit the nail on the head with the first point that, a lot of this, despite the fact that some of us can agree about what's ethical or not, a lot of it comes down to trust, right? If we don't trust the decision makers or communicators, even if we might agree with the conclusion, that might actually undermine the perceived legitimacy of the decision that's being made. So I think that's absolutely right. One of the challenges that faces decision makers, which is just an unfortunate, I think, reality of decision making in general, but particularly in pandemics, is that we're going to need to revise the way we think about these things. we've seen in many instances what people might otherwise consider to be moving the goalposts, right? To say, we plan to reopen the economy at this stage of the pandemic once we see these sort of metrics occurring, and then lo and behold, a new variant emerges and we need to revise all of that, and you've now undermined the trust of those decision makers or the perceived legitimacy of their decisions. And that isn't necessarily the decision maker or communicator's fault. That's just a necessary sort of feature of having to respond to the pandemic. What we could have done better is to very explicitly and frequently engage with the public about the need to revise our policy response. We need to be nimble given the different things that might emerge. Here in Ontario, Premier Ford has identified particular dates at which we will remove vaccine passports, at which we will start to remove different public health restrictions. And many have been critical, I think quite rightly, that attaching these to dates is foolhardy, right? First of all, we've always been wrong whenever we think about dates in the pandemic. Prognosticating is not our forte when we're thinking about a pandemic. And so that's probably just going to undermine trust even further if we sort of hold steady with those dates, despite the fact that the pandemic has gone out of control at that time, or we revise those dates because of the same thing. Either way, you're kind of undermining the trust in the public. So we need to do a better job of saying, look, this is something that's tentative. It's in the public's interest to respond in a way that is nimble and can reflect these situational challenges and changes. So I think that's one thing. And then the other thing I'll point to on the trustworthiness legitimacy question, and I've felt this very acutely by being a commentator in the media from the vaccine task force, is that people don't care what I have to say, right? I'm an ethicist, I'm an academic, I sit on one of these tables, but they don't know me from Adam. And what does it matter if I think this is the right thing to do, or I'm prescribing how we might do this? To build trust, we need to do that at the ground level with communities. And this is particularly important when it comes to things like vaccine hesitancy. Hearing this from your primary care practitioner, your faith leader or community leader goes so much further in building trust and legitimacy than hearing it from me, hearing it from Premier Ford or our Minister of Health. So that's another way we might think about, it's the same message perhaps, but it's who's delivering it, and can we leverage trustworthy relationships in the first instance to help with that. And then I think your point is really good about the trade-off of harms. In many instances, I think that's probably a missing point here, because if you were to say lockdowns or school closures are the acceptable or more justifiable option given the different harms that might accrue in either scenario, the tipping sort of point to favor that might be the fact that we can mitigate the harms in one scenario and not the other. And this is an argument that's been made where if people die, we can't compensate for those harms. We can't mitigate those harms. Death is final. Long COVID, in many instances, can't be mitigated. Economic harms or social harms, they're bad, but we could compensate them perhaps through CERB, other sort of programs that might be able to address them. So the presence or existence, or at least even possibility of mitigating those harms is one of the things that might actually justify accepting those harms and doing something about it. So I think that's a great point that we could emphasize a lot better in our public communications about this.
Thank you.
I'm wondering, are there other questions we have coming up or comments people want to make?
Rita Wong.
Thank you. Thank you for that talk. I'm over in Vancouver at Emily Carr University of Art and Design, and we started the semester thinking that we would have a vaccine mandate in place on campus, and here we are in November and we don't. I appreciate your points about all the logistical challenges. Like, we've been working through that with our administration. I was wondering if you could go into more detail about examples where the mandate has either worked or not worked, and if it's something that we should continue to advocate for as a faculty association. I certainly hear loud and clear from some members who want it, but I also know there are members who don't want it. And this trading off of harms is a difficult balancing act.
Yeah,
so,
thanks, Rita. I mean, we might be here all night if you want me to talk about mandates. I'm a strong believer in mandates, but of course, as my presentation really alluded to, the details need to be there, right? We need to get the details right. And procedurally, we need to arrive at these decisions in a way that's seen as legitimate, inclusive, and fair. So, you know, I think in many ways, mandates on campuses are something that we still have public health benefits, can still be justified in many different ways. Some of the examples that I think that we've come up against is, does this actually improve vaccination rates? Does it improve coverage in a particular setting like a university or not? A lot of this comes back to what is the ultimate goal of a mandate? And I think that's something that it seems so simple, but we're not good at articulating this, right? People say it's a benefit, but there could be multiple different benefits that we might think about with a mandate. One is just getting more people vaccinated. One is improving coverage in a particular setting. Even if it doesn't increase the number of people vaccinated, at least everyone in that setting is vaccinated. It could be just to protect critical infrastructure, right? The fact that if we have professors getting sick or hospitalized or dying, or students being hospitalized or dying, this can threaten the operation of a university. This is even more apparent, obviously, in hospitals and other settings. If you have people getting sick, this can really undermine critical infrastructure. And then finally, you might just say, look, even if we don't care about increasing vaccination rates per se or coverage, we know that vaccines are very effective at preventing hospitalization. And given what we've seen in some provinces about the overwhelming of health systems, we might say, look, even if vaccines don't prevent infection or transmission, and of course there is evidence that they do reduce risk of transmission and infection, but even if they didn't, they reduce risks of hospitalization. And we don't want hospitals to be overwhelmed. So that's another reason why we might support mandates. And so the issue here is when we're debating whether a mandate is still necessary or important for a university, or for a university like mine, like Western, when will it cease to be necessary? When do we think about getting rid of this? We need to reflect on, well, what was the objective in the first place? And what objectives are we actually trying to achieve? Because if we look at one metric, like increasing vaccination rates, well, we've done that. And so perhaps that's not going to be necessary at some point. If it's to prevent hospitals being overwhelmed, that might be something that you might need to have a mandate in place for some time, right? So it will really depend on what that overarching objective is. So I would suggest that just being very clear about what that is will really help for people to get at least on the same page about whether this is something that would be ethically justifiable or not.
If I may just follow up a little bit, the challenge, I think, is our employer is like, well, we can implement it for the employees, we cannot implement it for the students. And so then the next step is, of course, well, if the students don't have it, then why should anybody have it? So it's just the downward slide. And so it gets into issues of power, I think, not so much as ethics, or both, I guess, yeah.
No, I think, issues of power get into issues of ethics, right? Because of, I think that's absolutely right. I mean, the one thing I would say in response to that, I suppose, is that many institutions in Canada have introduced mandates that apply to students. So it's not entirely clear why it couldn't be done at another institution. Of course, there's differences. It's very easy in one sense to apply a mandate to staff and faculty because it's our job and it's an employment condition. For students, I teach big classes and I don't even know if they're all Western students, right? So it's very hard to adjudicate this sort of thing. Sometimes it's just knowing that, look, there might be some limitations in enforcement, but otherwise this is the thing that we think is important for the general health of our population. And so is justifiable to do. So Rita, if you'd like to reach out, I'm always be happy to chat about this further and share some of the gnarly sort of things that we've had to engage with behind the scenes to make sure that this is an ethical policy moving forward.
Thank you.
Bill Bruno is next, and then I have a chat question.
All right, very briefly, because this is my second chance. We have a case at UBC of a man, prof, well-known one, who announced in the first week of classes in September that he would not be teaching unless he had assurance that every last person in the classroom, all 93 of them in one case, and all 41 in another case, was vaccinated. And he's announced this as a challenge to the administration. So there are a couple of points that you raised about how leaders and administrators are going to face up to problems like this, and the question of balance of harms was raised indirectly by Michael Byers' case. It was heightened in our instance because he's quite famous. So he made page one of the Globe of the Vancouver Sun, and I think the administration was compelled to pay perhaps a little bit more attention than it might otherwise have done. He may be online for all I know, so he may comment on this himself. At any rate, the questions that you raised about how leaders deal with these sorts of things is quite important, it seems, in a case like this. And Michael is certainly not the only one in the country. So there must be a number of people who are simply standing out against mandates of any kind whatsoever. It is a bit of a problem given collective agreements and questions about academic rights and academic freedom for that matter.
Yeah, I think this is another place where, you know, a lot of reasonable people might come down on the conclusion that mandates can be ethically justified, but these are the things like collective agreements, labor law, other things that need to be sorted out if we're going to actually pursue this in policy. And those are often the things that the senior administration is having to grapple with as they create such a policy that those who might be opining about whether this ought to be done don't have to engage with. They don't actually need to think through what are the implications for the collective agreement or for labor law or whatever it might be. What are the challenges that decision makers are actually facing? You know, I think I've seen many instances where professors or staff or students even have said that they would refuse to come to campus unless such a policy was put in place. And again, I think in many cases that has been done given this view that the administration doesn't actually agree, right? And I've seen it where I know the administration happens to agree with that. They're just trying to sort through how to actually do it. And my challenge to most who have said as much publicly is to say, well, help them actually try to navigate those gnarly issues that is perhaps preventing them from putting such a policy in place. So if they're really caught up on how to provide exemptions when they receive requests for medical or religious exemptions, and that's the thing that's preventing them from releasing the policy, help them navigate that. It's not enough to say this is good. We need to say, well, how will we actually deal with that? So that would be just one of my responses to that. I think it's, you know, it's also performative in another way, right? That, you know, I sort of didn't play up that side of it, but sometimes we make these arguments in public to push the public dialogue and push decision makers to be accountable to think about these things, even though we know that it is more challenging and more needs to be done to think through those nuances. It's something we need to do to advance conversations in a public way. So that's another way that might be happening. Thanks, Bill.
So Dr. Smith, I don't know if you can see your chat right now. I can read the chat question.
Yeah, if you wouldn't mind, that would be helpful.
Yep, okay. Campus community, I'm going to read it now. It's Anna Brie Fairweather. Campus community members are saying they need more information about COVID cases on campuses and in the classroom. Institutions in British Columbia are not tracking COVID, nor are they reporting information. Should faculty and students have more information about COVID cases?
Thanks for that question. I think ethicists are renowned for equivocating and not having a clear answer. I think yes is the clear answer here. I'm happy to stake my claim in that particular response. You know, the one important thing though, which I've tried to advise senior leaders about this, is transparency is good, right? To say, you know, what are the cases we're experiencing? What are the outbreaks? Who's being affected by this? Are different groups being disproportionately affected? Sort of the equity question. It's good in its own sense to provide that information, but if it's an institution or a government doing it, they also need to say, what are they going to do with that information, right? Because it's all well and good to have that information made public, but if our students and our staff and faculty are looking at counters for our university and the cases that are accumulating and nothing is happening, then we might think that this is a dereliction of the duty of the institution to intervene. Or if we don't see any cases coming into place, people might say, well, why are we mandating vaccination? Or why do we have occupancy limits on rooms? Or why are we physically distancing or wearing masks? So I think with the transparency of communicating that information to our staff, faculty, and students and to the public, we need to at the same time say, so what does this commit us to? And this is difficult because setting thresholds is often difficult, and just like setting dates, we can really, you know, prove ourselves wrong a lot of the time. But I think we do need to say, look, if we see a certain number of cases that we would think would jeopardize the health of others, that will trigger a response that might mean putting classes online, It might mean more physical distancing on campus, or stopping recreational activities or other intramural activities. And if we don't see cases on campus, that's not sufficient warrant to get rid of masks or not have the mandate for these reasons, right? And so I think you're right. And I think the easy answer is to say, yes, we should be transparent about this, but it must come with some communication of what does that commit the university or institution or government to do should we see cases or hospitalizations or whatever it might be increase or not.
I'm very struck in the case of the university about how when we talk about campuses, we tend to talk about them as monolithic institutions. And of course, there's the whole trajectory of age groups. There's, as we all know, any of us, we sometimes teach in old, you couldn't even call air moving in some of the I've taught in. Other times there wouldn't be a problem. So the thing is, it's not even as simple, it seems to me, as kind of a policy that fits one group or another. It's also the complexities of trying to deal with the institutions.
And this is why it's so incredibly important to make the decisions in a way that's seen as right. So we can sometimes agree about substantive conclusions about what ought to be done, but back to a previous point I think that Kevin made, if we don't reach those conclusions in a way that's seen as inclusive and fair, then people aren't going to see them as legitimate. So as we all know, leaders can be quite aware of the different issues that might be affecting their campus population, but they can't know how certain populations are going to be affected or not, or how they might feel about a particular issue or not. And they can only become apprised of that if they engage those populations. Mm-hmm. Even if that doesn't really move the needle on their decision, the act of engaging them and having their voice heard and informed decisions is a really important procedural value to ensure that we're making legitimate decisions. So I think that's a crucial point on these controversial issues. We need to make those decisions in ways that are seen as legitimate.
Right. So last words, future ethical issues. What are going to be the hot button ones as we roll through this yet uncertain winter?
Well, I mean, I think there's a couple of things. One is there's an increasing appetite, mainly because we're sick of the pandemic and we've had good vaccination uptake, to just live with the virus, right? That we just need to get on with it. I think this is attractive for most, but we need to really be cognizant of the fact that we all experience the pandemic in different ways. And because someone like me might feel that the pandemic is over or doesn't affect me, may not be the case for some of our students, some other segments of our population that might still be very significantly affected by this pandemic. And so until all of us feel that we're safe and measures are put in place to adequately protect us, such as vaccinating children, right? Until all kids are vaccinated, then I think it's very difficult to argue that we ought to move on and sort of live as if this is the flu or some other sort of infectious disease pathogen. And the other thing I'll just mention, Penny, is that we've spent a lot of resources on this pandemic. There's been so many issues that we've had to tackle as governments and as societies, simply because we had to, and that has been financially very difficult for, I think, a lot of institutions and for governments. And so my worry is that we might transition into a period of austerity following this, where we say, look, we had to expend so many resources during that pandemic. Now we need to really cut back on social and health service and other sorts of services that are crucially important for different populations, for all of us. And that's precisely the opposite direction we need to go coming out of a pandemic, where we appreciate that actually those social supports and health supports are precisely the things that help us be resilient in pandemics. And so I hope that we don't go in that direction, but that is a fear that I do have. Not to end on a negative note, but that's what I'm thinking at the moment.
All right. If you have the patience for one more, Kevin McKay has just sent a chat, and I'll just read this to you if you have any comment. And then I think, barring seeing somebody with a burning question, we'll close. Kevin says, and yet, as I'm sure you'll agree, all of us will never agree on when to lift public health measures or to what extent. What's the appropriate threshold to make the move?
Yeah, that's a tough one. And that's, I think, what a lot of societies are now facing. Again, I think crucially in that discussion, or in thinking about the answer to that, we can't just look to the majority or the most advantaged in society, right? Because for a lot of that group, it's time to move on. And well, I don't even think that's necessarily true, but a lot may perceive it as time to move on. And so if we take our commitments to equity seriously and to social justice seriously, we need to think about those populations who moving on would disproportionately affect. And so we can think about different populations within Canada that would affect, but also internationally, right? If Canada and the United States and other high-income countries want to rely on their vaccinations alone, even though this might increase hospitalizations and deaths to some degree in our countries, the toll that might have in other countries may be pretty significant because we're contributing to the spread of the virus. And so I really do think that this decision really needs to account for the worst off and least advantaged in making that decision. I think one very practical metric that needs to be there is the ability for everybody to be vaccinated, or at least everyone to have the opportunity to be vaccinated. And that's why any decision to just allow the virus to be endemic or just to exist without significant public health measures in place, without a whole population under the age of 12 not even having the opportunity to be vaccinated, is very problematic. At the same time, we're seeing the need to have third doses to really restore the protective benefits of the vaccines. I think it will be very difficult to argue or defend that we ought to just move on and lift public health measures until everyone has had the opportunity to receive a third dose and to restore the benefits of the vaccination. I'm not going to suggest that once we do both of those things that we'll be in the clear, because we've seen certainly some jurisdictions remove mask mandates and other things only to see their hospitalizations skyrocket and have to resort to lockdowns and things like that again. So again, back to a previous point I made, we need to be very clear that yes, we are willing to ease the restrictions that we have, but there are going to be metrics that might require us to reintroduce those, right? And really socialize the public to that idea such that they don't feel that they've been duped in some way by doing so.
Thank you.
Thank you.
I want to thank you for your very generous time you've taken. And Fairweather says it was a fantastic presentation. And really, it's been so interesting to have you with us. And I'm so glad you could come. So thank you so much, Dr. Smith.
Thank you, Penny, and thanks everyone for your contributions and time. I've put my email in the chat. Please feel free to reach out if you have any questions or would like to chat in the future.
Thank you.
Thanks all.